features, but we're going to focus today more on the people that are on the more depressive side of the spectrum, the unique considerations both before their infusion, during their infusion, and after their infusion, kind of like we did with the previous podcast. So briefly, what is depression, right?
Mm-hmm.
I mean, I think most people have a general sense of depression, or they will label it as being unhappy, but it's much more than that, right? Oftentimes, depression is typified by, there's a DSM criteria for it, but a list of things, it could be insomnia, weight gain, anhedonia, this sense that the typical things that would give you pleasure, you just can't get pleasure from those things, right? You can see a cute baby smiling and you can sit there just empty, right? And there's more things, but at the end of the day, people have a general sense of like what depression is. The unique things when people come to us for a consultation with depression is oftentimes they feel hopeless. And their entire experience and life up until the moment that they make contact with us, for the most part, nothing's worked for them.
Right.
And so they have built this narrative, and it's not based in, it's not fictional, it's real. This narrative that tells them that nothing works for them. They are the patient that nothing works for.
Right.
Everyone else, there's something that can fix them, but not them. They're different, right? And I don't mean that in a demeaning way, but that's how most people feel when they talk to us. And so my job as the clinician when I'm discussing with these patients is trying to just show them the evidence. I do tell them, of course, this isn't a magic bullet, doesn't fix everything, but there's a lot of evidence that for patients with depressive features that this can work really well for you when other things haven't worked. Right? From a therapy standpoint, when a depressed patient comes into your door, whether they're doing ketamine or not, what are kind of the unique considerations you think of when you're first starting off with them, like the way that you discuss with them and work with them?
I always think of it as mild to moderate or moderate to severe. I'm always kind of trying to we do assessments for that to figure that out.
Totally.
But I would say if they're coming for an IV infusion, they're going to be more moderate to severe. For
sure. You're not coming in with a touch of depression here.
Exactly. Which basically means they're having trouble functioning at work, in life, in relationships. They're really, really struggling. And I think, what we tend to see is also the clients that really have high suicidality, which, I know a patient that you and I both worked with where it was like the thoughts of wanting to die were just constant, and it was like an act of torture just to be alive in that body, and ketamine worked. And so I think, we were talking a little bit about anxiety and some of the challenges with anxiety. The beautiful thing with depression is people are coming in at such a hopeless space. And a lot of times they're like, nothing's worked for me. I don't think this is going to work. But the research is showing about 80% effectiveness, which is phenomenal when you think about it. Right.
Because that's with people that other stuff hasn't worked.
Exactly.
That's insane,
Exactly.
It is really quite remarkable.
And pulling them out of that space of, it's like a whole body, depression is affecting their entire nervous system. So they're not, they're tired all the time. All of that stuff can actually improve. So it's
tired and they can't sleep.
And the sleeping.
It's a vicious combo, but it's pretty typical, unfortunately. So I think, when they come into the clinic, depressed patients, obviously, there's a spectrum of them, but they tend to be very blunted, but also at the same time will get really easily tearful. Like I had a patient today, I would say within 30 seconds of coming in, just started crying. With, seemingly a pretty benign story, but it was just, they were finally in a place where they felt like they could just feel. And I can sense that this patient had already been to this space before, so I can sense they were primed for it, oh my gosh, I finally get to feel again. But they just, the threshold to fire off emotions is really low.
Right.
And that can sometimes manifest with overload where they're very blunted, or other times manifest with crying out, or intense impulsive behaviors and anger and things like that. It goes all over the place. When they sit in the chair, I think one of the most important things I need to do as the clinician is emphasize with them that this is just the start. Like how this single experience goes for you today does not determine how you're going to do over the course of the induction. We think of these 6 infusions that we do as one treatment, right? Yeah. So each time we're kind of continuing to fulfill the treatment. It's just part of it. You're going to be working with our therapist. That's a huge part of it. Yeah. And each experience is going to be different. On the whole, depressed patients tend to have more satisfying, bigger experiences.
Right.
Maybe can you speak to why you think that's the case? Like, why do you feel like a depressed patient has a bigger experience than an anxious patient?
Well, I mean, one, we talked about with the anxious patients, they're gonna be holding on tightly and like want control. The depressed patients are just desperate for relief. Yeah. So they're actually kind of really open in a way. And I think that that's a part of it. And then I think there's something about the medicine and the hope giving and the like spark of life giving that we've talked about that is so refreshing to a depressed person because it hasn't been there for so long.
Right.
And so I think, I don't know if that answers.
No, it does, yeah. And it's my experience like sitting through so many of these is you can almost see the weight come off them. It's like palpable.
Yeah.
And when they come out of it, I mean, a lot of times during it, they're really emotional. A lot of them are crying through their eye mask.
Right.
It takes a lot of restraint to not want to console them, but I think it's really powerful for them to kind of go through what they're going to go through.
Yeah.
And then afterwards, a lot of times they'll recollect either re-experiencing prior things that were really beautiful. Like today I had someone that was talking to their father who died 15 years ago, and he didn't realize like how much that death still was with him and how much he missed him.
Wow.
But we've also had people, you know, swimming with fishes, and they loved snorkeling, and they hadn't done it in years, and how that, like, just feeling a sense of joy again when you've just been in such despair for so long, just that glimmer of like, wow, I can feel.
Right.
That can kind of kickstart the positive things happening.
Yeah.
Right. I think it's important as the clinician to emphasize that this is not going to be a straight trajectory. Just because you have a great experience the first time doesn't mean every time is going to be that way. And it doesn't mean that you're not going to have depressive symptoms moving forward. You will likely have some form of depression your whole life if you kind of trend that way. But is it we don't want it just to be as severe, right?
Yeah.
And so you're going to have these peaks and troughs, but hopefully we can kind of bring them more towards the center of like a more stable middle way experience.
Yeah. And would you say, I know we talked about this, but like the third session is where they start noticing the benefit the most?
I mean, I think that's what like maybe the evidence would show.
Okay.
It's so hit or miss.
Yeah.
Like today, this person was on their 5th and like just starting to get signal, like this is helping them.
Okay.
So like, this should happen to be more on the anxious side of things, but still like some people after the first one, it's like, that's it. Like I know it's gonna work.
Right.
Other people, it takes time for them to kind of see it working and to kind of really manifest.
Right.
And again, just like with the anxious patients, the depressed patients can look for any signal that this, rather than maybe focusing on the side effects, the depressed patients focus on any signal that they're still feeling depressed.
Yes.
As a confirmation that
it's not working.
This is not working. Right? Of like, I was doing well and I was walking with my girlfriends and that was good, but then when I got home, my husband said something that really upset me, and then I just started spiraling. I don't know, like it just feels like I'm right back to how I was, and I'm upset. And it's like it's not working for me. It's like it's okay. Like you went and you were walking with your girlfriends. Like it's not going to be a perfect trajectory.
Yeah.
Just even when this is done, it's not going to be gone. Right. It's something that you're going to be working through for a long time, and that's really where we think of this as a catalyst for healing. Of like the ketamine is just kickstarting the therapy process, and that's really. It's your job to kind of carry them through and beyond. No pressure.
Right.
No pressure. But it's your job. So what is the therapy like? What, like when patients are discussing, like think about maybe a patient that had a really typical big transcendent experience. Like what's that first session for you like when you're talking about it?
I mean, I think it's almost like colors brought back into their world. I mean, because we talked about how So I think they just, their experience of life becomes full again. And we were talking about this. I think one of the misnomers of people that are depressed is that they just want to be happy. But is happiness really the goal? You know, I don't think so. I mean, the goal would be to have a fuller expression of emotions and a fuller experience of life. So being more mindful might be a good word, or what kind of words would you use?
Yeah. I think I like mindful, but also mindful for a lot of people is like, oh, you want me to like go to a yoga retreat, and it's like so that could be like weirdly triggering. Content, or like there's a term of like metacognition where you can just be aware of your feelings, like get to a place where you can like see your feelings as feelings, but they're not controlling your behaviors. That's the holy grail.
I like that.
So if we're trying to achieve something, the ultimate is to get to a metacognitive state. And that takes time, and I think it's aspirational. But you're so right though. Like the idea that the opposite of depression is happiness. I think
like to work on the expectations with that.
That is setting you up for failure.
Yes, 100%.
That's your job, honestly.
Yeah, and I guess the hard thing with depression is people get into a place of being non-active with their treatment because they just physically don't have the energy to do the things that are going to help them feel better. So I think it's super critical while they're getting the treatments to implement exercise routines, nutrition changes, all those things that they have to actively do on a daily basis in order to continue having, good mood, basically. And there's so many, things that we can list on that list. Nature, meditation. I mean, we've gone over this in other episodes, but I think the thing for me with depressed clients is trying to get them to take that active responsibility for themselves, because at some point they've given up responsibility and given it to the medication, and I understand that. I mean, I was definitely one of those people where it was like nothing really worked, so why bother? At the same time, I love the podcast like 10% Happier, where it's like every little thing we do adds a percentage. So you can't just like, again, ketamine's not going to be the silver bullet. Are you doing all those other things that are really, really critical to be a healthy person and overall well-balanced person?
I think a unique consideration for maybe the extreme end of depressed patients is suicidality. We work with a lot of patients who at the very least have suicidal thoughts of like kind of vague idea of like not wanting to live anymore, they'd be better off dead. That is very different than suicide with intent or plan, right? Thinking more on the kind of suicidal ideations or thoughts, vague thoughts, that spectrum, I stand on strong evidence that ketamine is, if not one of the most effective rapid treatments for suicidality. And I think you'd be hard-pressed to find a medication that works better. And I think it's incredible to have a comprehensive team and do therapy and stuff like that. But when someone's really critically suicidal, I mean, I think you'd be hard-pressed to find a medicine that's more effective. And I see it constantly in here. Now, with that said, it's not to say that suicidality doesn't creep back up with these patients. We've seen it before with some of our mutual patients. And it's really hard, actually. My training originally, and still I work as an ER physician, emergency room physician. We see the extreme side of suicidality with, suicide attempts or patients placed on psychiatric holds because they have a plan to kill themselves. And I've kind of had to like almost detrain myself from this reflex of like, wait, did you say suicide? Anything resembling suicide? Like, you gotta go to the hospital. And I've had to like work my way back to be like, okay, let's explore this more of like, what do you really mean by when you say that? And have you ever acted on it before? Right? There's a lot of things that we can do. Psychiatrists do this all the time to develop an idea of like, what is your likelihood of actually following through with the plan? And ultimately, our job as a clinician is to determine, are you safe moving forward with this treatment, or do you need inpatient care? And there have been times that I sent patients to the hospital.
Just a few weeks ago. We had someone that we both,
not too long ago, and they needed it. They were hospitalized for 8 days. And so like, there's a time and a place to be in a safe, enclosed environment. But there's also a time and a place for patients that have vague suicidality without an intent or a plan to come and get this type of care. When patients describe like suicidality to you, like what do you make of that? Especially ones that have never like attempted before, but like 30 years of suicidal ideations, like what is that?
I mean, I haven't had that. 30 years would be a long time. Wow.
Let's say
a year. I mean, I would say for most people, it's not, I mean, except for that one that we had, it was like a chronic chronic.
Because I have seen that. I've seen a lot of chronic suicidality. 30 years is probably a bit exaggerating, but there are people that live with like vague thoughts that they'd be better off dead their whole life,
right?
Or for much of their life,
right?
And I mean, that's, to me, that is a version of suicidality.
That's awful.
Or like I wish I didn't wake up. I could just be asleep all day.
Right.
I don't know how that's different from suicidality. Like, at the end of the day, like, how do you? I mean, the medicine obviously helps kind of unlock different ways of thinking about things, but how do you, when you're doing the therapy side of things, try and show people what those thoughts really are in terms of, I don't know, maybe just the
Well, I mean, I like to figure out when it's getting activated. So are there certain shame cycles, or are there parts of themselves that were injured in childhood that bring that hopelessness up to the point where they want to kill themselves? Because oftentimes it's not, I mean, there are people that have it chronically throughout the day, but oftentimes it's like triggered at certain points.
Yeah, that's a good point.
By their thoughts, and so we're trying to understand like what is it that's activating that. And then, you know, constantly assessing like the plan. Is there a plan? I mean, when people have vague thoughts, there's not a high risk of them actually doing it, but if they have a plan, if they have a specific way that they've thought of doing it and they have access to that, that's when we're really concerned. And I mean, that was the situation that we had, that we had to deal with.
Yeah, no, for sure. I mean, it's a tricky space, and I think, you know, from clinical side of things, the easy thing would be to like not work with that patient population, right? If I'm just being totally transparent, right? Because it's like not just from like a liability standpoint, but from just psychologically, like you feel like at any moment, if you don't help them, that this could mean they die. Right. And like obviously it's not maybe as extreme as that, but I mean, I'm human too, and we kind of build it up in our mind that way. But at the same time, having done this for as long as I have now, like, gosh, I've seen so many people that have been suffering for so many years with severe depression, and it's like they become a new human. It's so incredible, and so that's what kind of keeps me going when we do have the more difficult ones that maybe aren't progressing as quickly as we want, and that gives me hope. Now, I think the depressed patients during the kind of subsequent infusions, like I said, they're oftentimes comparing their best infusion to this infusion, and I think we've talked about this before, but I think it's important to emphasize that the experience itself in the infusion is not predictive of how long this medicine is going to work for in terms of like the durability of the effectiveness. You don't have to be like you know, swimming in a rainbow every single time to get the most effect from this. That's cool, but it's not going to tell me that 3 months from now you're still going to be doing well. And
we have seen the more severe need more of the boosters.
Yeah, that's very true. I think
pattern.
It's very uncommon for someone with really severe depression to do 6 infusions and be like, quote, cured after that. Right? Yeah. Now, I think that there is some patients that we've had that will do that and then continue to work with therapy and be on their normal medicines that they can kind of slowly de-escalate. But more often than not, we find these patients getting a lot of benefit from periodic maintenance or booster infusions. Typically, we're doing it about 4 weeks out after their last infusion, sometimes a little bit closer depending on the severity, and then we slowly taper them off. And there are some patients that are doing it once a month, but more often than not, it's every couple months. And I think it's great. I think it's a great way for them to like kind of reconnect with this space and the mindset of what got them out of their depression in the first place. I think from a neuroplasticity standpoint, sure, like there's a couple days of it, but I think it's more about just like going back to the place that my healing started. Maybe even more so than like the neurobiological changes. But I don't know. It's hard to know. It's like I wanna think that they're it's opened up the connections and they're starting again. And maybe it's that, but one single session, I don't have much evidence to hold on that causes long-term effect. So I think it's more of just like, hey, remember what it felt like to like be here, be working on yourself and getting that sensation that there's hope that you can get through this. Oh yeah, I can still do that. And then they continue to engage in the positive behaviors. I don't know. I don't know if I have much more to to add? Do you feel like there's anything we haven't covered?
No, I think.
Okay.
Yeah, these are the patients that I are kind of like the most exciting to see the changes with.
Yeah. I mean, we love all of our patients getting better, but I think it's undoubtedly true rewarding. That the depressive patients tend to do really well in this space.
Yeah.
So, that's kind of it for now in terms of covering how ketamine works with depression. If you have any questions, feel free to reach out to us. We're always here for you, and we will see you next time. Bye.